Hello, everyone. Welcome to a holiday VMR. Excited to be here with Kirtan, who graciously agreed to discuss a case with me because Alec is busy doing some holiday festivities. But very excited to be here. Special thanks to Julia for presenting the case and to our scriber and teaching points and everyone that's helping out with that. But I'll pass it to Kirtan just to say a quick hello, and then we can get started.
Perfect. Thank you so much, Austin, for kind introduction. I am very excited as well for this Christmas week VMR. Like we always like the Christmas, whenever the festival comes up, our spirits to discuss the case and learn from our team members also grows. And I haven't seen Julia in a while. Like I think it's probably almost 4 or 6 weeks that she now is coming to present the case. So I'm so excited. Thank you, Julia, for presenting the case to us. And maybe I can pass the mic to Julia that how has she been doing in last few months?
Hello everyone, I'm Julia, medical graduate from Brazil, and I'm doing great. I'm very excited to come back and present another case for you guys.
Wonderful. Yes, so we can if we can go ahead and get the whiteboard up, then we can get started. And
So
Kirtan, I'm
let's
going to have you go first because we just have to hear your wisdom from the beginning. That's the most important thing. So, yeah, sorry, Julia, to interrupt. Go ahead.
no, no worries. So let's start with the chief complaint. We have a 30-year-old male presented to the ED with confusion that started this morning.
All right, well, this is a good place to start. And sorry, friends, I had to turn off my video because I know that my internet is not the strongest and my voice might be glitchy. So I think this might work well. So looks like we are dealing with a young gentleman who is presenting with acute confusion, right? Now, as always, in any aspect of medicine, when you are trying to deal with a problem, it's very important to clarify the problem, right? For example, this might be the acute confusion, but is this the first time that the patient is having confusion, or is this recurrent episodic confusion, right? So even framing this as the recurrent episodic confusion might change your approach, right? So first thing in such scenarios is to get a thorough history as to what do we mean by the acute onset, right? Is this the first time or is this the recurrent episode? Second thing, what do we mean by confusion, right? So for example, let's say if someone gets an acute onset MCA stroke and they become aphasic, when you try to talk to them, when you ask them the questions, maybe they are not even able to comprehend what you are asking them based on what kind of aphasia they have, whether it's like Wernicke's aphasia or Broca's aphasia. And based on that, they may not able to even answer your question. So you might perceive that, hey, this person is not even speaking anything at all, no matter what I ask. Maybe they are confused, right? So you would label it in a wrong way and you would go down the wrong path. You would think that, oh, maybe this person is intoxicated, but they are probably not intoxicated. Maybe they just have a focal neurologic deficit in the strategic location, right? So that's why when we use the word confusion, it's always nice to characterize it, that what does it actually mean, right? For example, what if I say that, oh, this is a person who has a history of schizophrenia, who is on bunch of medications and is now coming in this state because he or she stopped taking the medications, right? Then the story will be again different. So at this point in time, this is my first thing, that to characterize the time course, characterize the confusion well. And let's say, in case we are not able to make any progress by this like preliminary approach, then we can open our preliminary schema, that what can cause acute onset, some kind of mental deficits, right? So we go through the metabolic risk factors, we go to the infectious risk factors, we go through the structural pathologies in the brain, and then we go through the toxic buckets. And I know that we often use this mnemonic, like the mist mnemonic, but one easy way to conceptualize this is that imagine that if someone comes to you, what is the algorithmic workup that you can perceive, right? So someone comes up, you check their vitals. If anything wrong with their vitals, it can cause confusion. So you could imagine if someone is extremely bradycardic, extremely tachycardic, that can impact the perfusion to the brain. If their blood pressure is extremely high, extremely low, same thing. It can cause either hyperperfusion mediated injury or hypoperfusion mediated injury. Then you look at their oxygen saturation, right? Like if they're hypoxic or hypercarbic, that can also cause confusion. Apart from the vitals, what's the next thing which you will do if anyone comes to you? You will check like the basic labs, right? So anything in the BMP, you name it, like is it calcium being very high? Is it sodium being very low? Is it severe acidosis? Is it severe uremia? And similarly, you obtain the comprehensive metabolic panel. If there is a severe liver injury there, might suggest like hyperammonemia, right? So basically, any basic labs you can get, anything is abnormal in that, you can get the confusion. So this is about the basic labs. Then you can think about getting the infectious workup, right? Like you will get the imaging, you will get some blood cultures that can might point you towards the cause of confusion. If all of this is unremarkable, meaning that maybe the problem is not outside the CNS, maybe problem is in the CNS, then you go to the next bucket, right? That maybe you will think about getting imaging, maybe you will think about getting the lumbar puncture, maybe you will think about getting the EEG, right? So the reason why I mentioned all these entities is because often it can be overwhelming to think about each and every individual causes of confusion. But if you just ask yourself that, forget about the individual causes, but what's the routine workup I could get, right? So even if you visualize that in your mind, maybe you will hit something during that workup that will give you a clue, right? So that's my initial approach. And maybe I can pass the mic to Austin that how would he approach this?
No, yeah, that was brilliant and incredibly practical about how to apply this to the bedside. And I think the only things that I really want to echo are just what Kirtan focused on, which is really doing your absolute best to define what altered mental status is. I think we should all challenge ourselves as clinical problem solvers to not present a patient and say that they just have encephalopathy or they have altered mental status, say that they are um, have a difficulty with arousal, they have difficulty with speech, they have like, let's really define what the problem is so we can better solve it. And I think that's a really thing that I've challenged myself to do and then I try to do with the trainees. And recently had like a very interesting case that really like I think impacted the patient's care in a positive way by really trying to refine what the problem was. So I think I just wanted to echo that point a lot. I think from a practical standpoint, I think it's unique that this is a 30-year-old man that's coming in with confusion because assuming that the person is healthy and has no medical history, it's odd to see such a young person develop confusion because the reserve of the brain and the body, generally speaking, is so high. And so you'd have to ask yourself, okay, if this, we're going to learn if the patient has vulnerability, and Kirtan sort of alluded to some of those things already in his discussion. But I think if we say we make the leap and say, hey, the patient probably doesn't have any vulnerability, then what are the most common reasons, statistically speaking, why that someone would develop confusion? And I think in such a young person, um, uh, Jeffrey taught us recently, I can't remember if it was yesterday or the day before, about substances being a key thing to work through. And I think that's something that you'd probably invest a fair amount in to begin with. Um, I think electrical phenomenon are open game because epilepsy, for example, or just seizure disorder, generally speaking, is common enough that you would wonder about if that could cause confusion. And then last, but uncommon, but no miss would be infection. And in a young person, like why someone would develop CNS infection, like there's certainly vulnerabilities could be at play, but you can certainly develop certain infections that don't require any sort of immunodeficient state for you to have confusion. So I think there's much to figure out. I think the other thing to approach here is like, okay, we're calling it acute. We haven't exactly defined the time course. And to Kirtan's point, we don't know if this is an isolated event or there's some history related to this, whether it's happened multiple times or if there's a tail. But I think in any type of scenario where you aren't yet confident in the time course, assume that it's hyperacute or acute. And I think the mnemonic that we sometimes use, or that Andrew likes to use, is the SCAN mnemonic. So S is for sugar. So let's just make sure that we get a sugar as soon as possible. C is for scan or CT scan. So consider imaging the person's brain. A is for ABG or VBG. So you want to get a gas to kind of check into the metabolic phenomenon that Kirtan alluded to. And then last is N for Narcan naloxone. So that's usually an intervention that's worth delivering. I also use the one called DON'T, which is dextrose, so another way for sugar. O is for oxygen, N is for naloxone or Narcan, and T is for thiamine. So there's a fair amount of overlap between those two things. But yeah, really interesting start and talked for already 10 minutes on on a one sentence. So thank you so much, Julia. Let's hear the next aliquot.
So going on to more detailed information for you, the history was obtained by both the patient and family members. He reports that on the morning of the presentation, he awoke feeling unusually foggy and disoriented. While attempting to log his computer for work, he was unable to recall the password, prompting him to contact technical support. During the interaction, the support staff expressed like concern about his mental state and asked if he was feeling well. He subsequently contacted family members to report this confusion. And per family report, at that time, he was unable to recall the current year or the president. Shortly thereafter, he stopped answering phone calls, prompting his family to send a close family friend to check on him at home. Upon arrival, the friend found that he was unable to open his door, stating that it was locked or jammed, though the door was easily opened when the friend attempted. Due to this ongoing disorientation, he was brought to the emergency department. He denies any no falls or head trauma, though he was noted to have blood coating in the inside of his lower lip. He denies any focal neurologic symptoms, including slurred speech, facial drop, weakness, numbness, or tingling. He also denies any previous episode similar to this presentation. He reports adequate oral intake in the days leading up to the presentation, denies fever, chills, abdominal pain, chest pain, cough, dysuria, or recent sick contacts. He just endorses mild shortness of breath and several days of mild fatigue preceding this episode, and reports sleeping like more than 20 hours 4 days ago. Additionally, he usually has around 2 to 3 bowel movements per day, but says that the last one happened last night, so around almost 24 hours before the presentation. I will just stop for now just to see what this changes your clinical reasoning.
Wow, yes, quite a rich history as we talk through. And so I think I will maybe focus on the initial aspects that delivered and then have Kirtan sort of talk through how he's thinking through what seems to be some sort of preceding symptoms to this patient's presentation. So I think whenever you see a patient that has confusion, I think while it's wonderful to get a history from a patient, you always have to remind yourself that the quality of the information that you receive is directly proportional to how the patient is able to deliver it. And I think if the person was unable to answer their door because they thought it was locked or jammed, in fact it was not, I think it leaves the quality of the history to be an open question. So I think obtaining collateral, like it sounds like coworkers, family, like there's people that care about this person and are invested in their health. So I think relying on them to get as much information as possible when you first start out is really, really crucial because while the patient is not withholding anything on purpose, I think you just have to understand that the information they're delivering to you is probably an incomplete picture of what's going on. And so you wouldn't want to frame the problem strictly around what the patient's delivering to you. And this is something we encounter commonly in the space of dementia where we rely on the family, but ultimately you just have to do more objective testing to get to the bottom of what's going on. And so that might fall into play here, but we'll have to see. I think my takeaway is that if I'm trying to summarize and refine a bit more about what the actual problem with the person's mentation is, it seems to be that we have maybe a bit of alertness, but I think the way I summarize it was like we seem to have pretty significant frontal lobe dysfunction, right? The person is foggy. They're not able to remember their password. They cannot open the door successfully. They cannot answer telephone calls. So this is a little bit of a leap to say they have frontal lobe dysfunction, but that's how I'm putting it together. I think the other open question is like, is there basal ganglia disease? But here I'm taking to talk through things a little bit more, but that's how I was kind of putting it together. And then lastly, as far as the trauma history, I think going back to the beginning of like why a 30-year-old would develop issues with their mentation. And I think trauma is like definitely a common one, generally speaking. And we don't have any history of that, but we do see that the patient has blood in their mouth. So one is there could be like, was there occult trauma that we missed? Or is this a reflection of maybe like the patient injured their mouth in some way, whether that's from a trauma or that they bit themselves, thinking that this could be seizure with the patient being having some being in a post-ictal state or continuing to have some amount of non-convulsive seizures is an open question. I think what would be helpful to refine that is to look in the mouth and see where exactly the injury is. Is it on the lip? Is it on the tongue? And then in particular on the tongue, is it in the front of the tongue or the side of the tongue? Because really it's the lateral tongue bite that is most useful to give you information about whether a seizure happened or not. A injury on the front of the tongue isn't particularly useful necessarily. So those are my initial thoughts. I'd love for Kirtan to layer in and then to add in sort of the background of what the patient is experiencing to refine how we're thinking through the problem at this point.
Sure, perfect. Thank you so much, Austin, for laying down that beautiful framework. And I wanted to highlight what Austin did, that he's trying to figure out that where in the CNS is the pathology. Because whenever we use the word altered mental status, what are we trying to say? We use it very loosely. We try to say that probably patient is fluctuating in the mental status. Maybe they are not able to orient themselves to the questions we are asking. So in a way, we are implying the global cerebral dysfunction. But you could imagine that very easily you can be fooled if there is a strategic defect in particular part of the brain. So like as Austin said, that when people have frontal lobe dysfunction, often they can have dyspraxia, they can have like problem with the coordination of different parts of the like their mental functionality, and you can have something known as disinhibition, you can have something known as executive dysfunction, all of which can present in this manner. So I extremely emphasize everyone to follow the same approach, that rather than loosely using the term AMS, try to figure out what's wrong with this patient. So what struck me most importantly was that this person doesn't have any focal deficit. And secondly, it looks like that maybe the higher function is involved rather than the lower function. So this patient was not able to open the door. That makes me wonder if this person has some kind of inability to figure out that how to put their hand on the handle of the doorknob, how to turn it around and how to pull it. They probably know that this is the door. They probably know that this is how it should be opened, but they're not able to do that sequential tasks. So that is what is known as executive dysfunction. And executive dysfunction can localize to many parts of the brain, but frontal lobe is one of the key aspects of it. And often we call it as like the dorsal prefrontal cortex, which coordinates everything with the thalamus, and then thalamus coordinates it with the limbic system, including your hippocampus. And that's how you go into this loop of utilizing your memory, which is stored in the hippocampus, and relaying it to the frontal lobe, which can cause the executive functionality and you can open it up. So that's what I'm trying to think, that does this person have a strategic focal defect rather than the global cerebral dysfunction, which is what we call as AMS, right? Having said that, if we try to focus on this history with, like Austin said, that what about this lip biting, right? That is this just a red herring or is it a real clue? Is it possible that when this person went to sleep last night he was fine, but during the night maybe he had like some kind of convulsive movements, at least of the oral region, which ended up causing him to bite himself, and when he woke up in the morning, maybe it was a massive seizure going on for a substantial amount of time, and now the patient is in so-called like post-ictal state, right? But Julia has told us that this has been going on for like few hours now. Now, in reality, post-ictal state should last variably from like maybe 30 minutes to 45 minutes, not longer than that. If it lasts longer than that, then you start asking yourself that does this person have non-convulsive status epilepticus going on, right? So as we are discussing in the first aliquot, that what would you get for this patient? You will get MRI, you will get LP, but then you will get EEG as well, right? So I'm keeping that hypothesis on back of my mind, that we will verify whether it was a true seizure or not. But if it was indeed a true seizure, how can we link it to the current state? Then maybe the one possibility is that they are still seizing, but in the non-convulsive form, right? Now, talking about this prodromal kind of constellation of symptoms which we have, that patient was fatigued, patient lost some weight, patient was hypersomnolent. We have to try to tie all of them together, but it's very important to again what Austin said, right? That what's the quality of this history? That are we sure that this is what was going on and nothing else happened, right? People can be hypersomnic for so many reasons, including the fact that they are just so fatigued during the day, and maybe they have underlying like vulnerability in the brain. Maybe that's why they are sleeping a lot, or it could mean that there is a strategic dysfunction of the sleep centers in the brain, right? So I'm still not sure if we should entertain the possibility of hypersomnolence syndromes, that what can be going on in the brain. But I would just highlight this key point, right? That what are the parts of the brain which mediates you to sleep nicely? So first is hypothalamus and diencephalon. Very important that whenever there is some kind of dysfunction to your hypothalamus or diencephalon, you will either have insomnia or you will have hypersomnia. It can go either way depending on what kind of pathology is affecting them, right? And apart from this, you also think about the brainstem, because brainstem has so many nuclei of different cranial nerves, and it also has the reticular activating system. So if your RAS system is activated, it can impact how you sleep. So I'm trying to figure out that why in a young person these unique parts of the brain might be affected, your hypothalamus, diencephalon, and brainstem. And one way to link all of them could be that maybe there is a toxic etiology which is affecting all of these findings. Maybe there is an autoimmune condition, let's say demyelinating disorder, which is affecting all of these structures. And finally, I would say that in a young male, you always think that what kind of tumor they can have, right? So in a young male, you always think about the germ cell tumor. And the reason why I bring germ cell tumor is important because most of the germ cell tumors are known to be associated with a range of paraneoplastic syndromes, and many of them are known to affect, in particular, the hypothalamus diencephalon, and can affect the sleep as well. So down the line, I would be making sure that when we examine this patient, we will of course examine every part of their body, right? But often the genital examination can be missed unless you are focusing on that, right? So in a young person with hypersomnolence, apart from their otherwise non-specific neurological dysfunction, I will always make sure that we get a good like genital examination and also thyroid examination, because we know that thyroid dysfunction can cause variety of things. So yeah, those are my preliminary thoughts. And before we move to the next part, Austin, what do you think we should get?
Oh, beautiful. Yeah. And I had to refresh myself on what the diencephalon is. So I appreciate your education. And yeah, no, I totally agree. I think if you're then layering everything you said with the patient's dyspnea, and fatigue, I wonder about the, if that could be signaled to a preceding infectious syndrome, or if it's, as you mentioned, maybe there's some sort of chronic vulnerability that this patient experienced, like cancer, and it just reached some sort of threshold that's now manifesting in this way. And I think shortness of breath is, um, it is really, it comes directly from the patient. It's objective. So I think if there's a way to objectify that with physical exam, it will be helpful. Otherwise, it's a little bit difficult to incorporate into our problem representation at this moment in time. Except, again, we're kind of saying, wow, like how common is it for a 30-year-old man to feel short of breath? Like I think it takes a lot for most 30-year-olds to feel short of breath. I'm 35 years old. So I think it takes a lot for me to feel short of breath. Like I try to exercise regularly. Like for me to feel short of breath just sitting in my house, like there must be something profoundly wrong with this person. So again, we're going to try to understand like what sort of history this person has. But I think all of these things are a clue that either there's something overwhelming this patient's body or that there's a vulnerability that has existed that we have really yet to clarify. So yeah, Julia, excited to learn more.
Great discussion so far. So, going on to past medical history, this patient has a history of hypertension, has asthma, hypoplastic left heart syndrome, did a Fontaine procedure in 2009, has iron deficiency anemia, was supposed to get an infusion today, but because of this confusion, lost the infusion, and had a history of six sinus syndrome, has a dual chamber pacemaker in 2009. From the meds, he took aspirin, ergocalciferol, furosemide, albuterol, and montelukast for the asthma, spironolactone, vitamin A, and zinc. No family history. From the social history, lives in Arizona, works with security. About the health-related behaviors, nothing significant, denies smoke, or alcohol or drugs, and has allergies to hydromorphone and lorazepam. Going to the physical exam, nothing very concerned. The vitals are stable, so temperature of 36.5, heart rate of 75, blood pressure of 126/62, respiratory rate of 20, saturation 94 on room air. General non-acute distress, alert and oriented within the emergency department, person, place, and time. Nothing on the hand. Cardiovascular normal rate, regular rhythm, S1 and S2 normal. Pulmonary efforts normal, breath sounds normal. No respiratory distress. Abdominal soft, normal bowel sounds. On the neural exam, no focal deficits, no sensory deficits or weakness, normal coordination, and skin is warm and dry. And about the beat, it was just like a beat in the lower limb as he beat the lower limb. It was nothing like a coagulation or something like that. And trying to answer Kirtan question, he sleep well, just wake up with this confusion and just started this morning. Nothing was going on in the past.
Perfect. Sure. Thank you so much, Julia. Maybe I can start and then Austin can layer on my thoughts. So, looks like if we had to summarize our problem, we are dealing with a young person who is otherwise was healthy, but is presenting with like acute onset of confusion and probably some degree of frontal lobe slash executive dysfunction on the background of prodrome, which involved shortness of breath, some degree of weight loss. We are not sure about the bowel movements yet, whether there was diarrhea or not. And the past medical history so far has been remarkable for this Fontaine procedure, which was done many years ago for something wrong with the heart, right? Now, how to put this past medical history into perspective? So, Fontaine procedure is like one of the procedures which happens in the pediatric age group, and from what I remember, that it's one of those procedures which you do when you have some degree of right to left shunt going on, or maybe your left ventricle is not able to somehow pump the oxygenated blood into the whole circulation. So you do the Fontaine procedure. So that way you kind of decompress and you make sure that still there is a way in which you can maintain the cardiac output. So that is known as the Fontaine procedure. It is the very well established procedure, but since it is very well established, it also has very well known complications as well. So if we just take a moment to make sure that we are not dealing with any complications of Fontaine procedure, what are the things we have to entertain? So in Fontaine procedure, because of the way you shunt the circulation, often there is very high venous pressures constantly in the superior vena cava, and all those high pressures get transmitted all the way back into your circulation, so including inferior vena cava, hepatic veins, mesenteric veins, portal veins, all through and through. And what happens when there is such high pressures in your venous system? Often you end up developing what is known as intestinal lymphangiectasia. So what it means is that the lymphatics of your intestine are so dilated because they are very congested upstream at the level of the Fontaine shunt when it was created. Because of that, your lymphatics are chronically dilated at the level of intestinal mucosa and submucosa, and you end up losing all the nutrients directly into the GI tract. So that is what is known as protein losing enteropathy secondary to intestinal lymphangiectasia from Fontaine procedure. Now, the reason why I bring this up is because when you are losing so many things in your gut, you can also lose number of essential vitamins and minerals which can impact your CNS functionality. So although this person was on some vitamins and minerals, that doesn't negate the possibility that you didn't develop any other deficiency, right? So in someone who has vulnerability like this person has, you should entertain all the possible nutritional deficiencies. So like vitamin B1, vitamin B3, vitamin B6, copper, zinc, B12, right? All of those nutrients and minerals you need to check and make sure that things are in the appropriate levels. Second thing is that since it's a shunt, and although we usually don't put a mechanical prosthesis there, but whenever there is any kind of shunt in the body, it is possibility that it could get infected, right? So is it possible that this person has spontaneous shunt which somehow got infected, and maybe this person has some kind of endovascular infection, and that endovascular infection now made its way to the CNS, and that's why patient is presenting in this way, right? And maybe perhaps that endovascular infection also somehow ended up affecting the lung parenchyma. So that can tie in what Austin was saying earlier, that why would a young person suddenly become short of breath, right? So that is like one hypothesis. Maybe infection complication, maybe the nutritional complications. But this is like just to be on the safe side, we entertained it, but it is possible that maybe it is completely unrelated, right? And then we look at the examination, that anything important we found. So all we know is that this patient is probably not well hydrated. So that's what we saw, that maybe there's some kind of dehydration. But apart from that, examination is fairly unremarkable. The vitals are also unremarkable. So again, adding to the suspicion of what Austin laid in the first aliquot, that imagine if this person had raging meningoencephalitis or raging brain abscess. Do you think that their vitals will be completely normal? Patient will be completely comfortable? Little bit unusual, right? Like if you have brain abscess or meningoencephalitis, maybe you will be like in so much pain, so much discomfort that it will show up on your face, or maybe it will show up in your subtle examination. Maybe the pupils are not reacting the way you want them to be. Maybe there is like a focal weakness in the arm or leg depending on where the brain abscess is situated. Maybe they will have like some kind of photophobia, neck stiffness. Absolutely nothing. Kind of makes you wonder more and more that where is the pathology in the brain? Is it subtle, like is it a molecule which is causing this, like a toxin or vitamin, or is it the electrical activity which is driving all of this, right? So, or is it the antibody mediated stuff, which is why it is not leaving a signature on major parts of the brain? So that's my preliminary thoughts, and maybe I can ask Austin that how to link this medical history.
Yeah, no, brilliant. And I think I think we were looking for this patient's vulnerability, and I think we found a lot in their past medical history. And unfortunately, it's this person's 30 years old and already contending with quite a few things. And I think I'm not too familiar with the complications of Fontan procedures, besides, as you mentioned, sort of the congestion that comes with the flow disruption when you have like a single ventricle or a pathway in which like you're not able to get the blood through the lungs and the heart apparatus as it should. And so um, I think linking in the vitamin deficiencies through protein lesion enteropathy is brilliant. And then I think otherwise, the other thing I would say is like if I'm trying to link in iron deficiency with this as well, certainly could go the same pathway, but if we instead invoke like a pressure phenomenon and say maybe the patient developed varices or has liver disease that we either haven't recognized to this point, most of the time if people are um, had a Fontan procedure, like and are seen interact with the healthcare system, like it's pretty robust as far as how they get follow up. Most of at least the places that I've worked have like congenital heart disease clinics, etc., that really follow these patients longitudinally. But sometimes things happen, life happens. Being a young person happens, and your ability to interact with the healthcare system is maybe not as robust as it used to be, and so you don't necessarily get the surveillance of complications that you would usually have. And so I think understanding that this patient might have liver disease and then that be a vulnerability to bleeding or encephalopathy or anything like that would really be interesting. But to your point, I think we get our exam and we have his initial presentation, and there seems to be a disconnect as far as how his mentation is now versus what was going on before. Yeah, I really don't have too much to add. I think it's just that this person has a rich vulnerability, and I think that maybe makes some of the more common entities that we might invoke in patients that are older, just because well, as you get older, you tend to develop comorbidities, maybe start to come into play a bit more. But we'll see how that hypothesis bears out. So, Julia, tell us what happened next.
Great discussion. So going into the labs, the white blood cell count was 5.7 with normal differentials. Hemoglobin was 12.8 at recent baseline. Platelets 146, MCV of 86, sodium 139, potassium 4.9, chloride of 108, bicarb of 18, creatinine of 1.38, which the baseline was 0.9, BUN of 27, glucose, calcium normal, calcium of 9.8, AST and ALT within normal limits, so AST of 43, ALT of 41, alk phos of 129, which is normal, total bilirubin of 1.8, which is elevated, and direct of 1, albumin normal of 4.4, total protein of 7.7, lactate 1.8. Urinalysis was normal, respiratory panel negative, and blood cultures after some days were negative. So I will stop here to see what is change in your diagnosis.
Well, yes, thank you very much. And as Kirtan mentioned in the beginning, we're just going to get sort of a baseline metabolic assessment of what's happening to the patient, and remarkably not too exciting. My takeaways were that, hey, this person's CBC is seemingly close to their baseline. The platelets are slightly on the lower end, so it might speak to sort of the congestion or liver disease hypothesis that we were discussing before as a complication of the Fontan procedure. And then some of the liver test results as far as well, I should say, some of the transaminases being mildly elevated in the 40s, understanding that a normal transaminase level in a person born male is probably around 30, and then in a person born female is actually around 20. So most laboratories that will not show up red, but technically these are elevated. So I'm tracking that as well as the bilirubin, which is slightly elevated as well in a direct pathway. So they're pretty mild clues, but more supportive of what seems to be a chronic component of liver dysfunction than anything acute, as best I could gather. And then, to the protein lesion enteropathy hypothesis, it seems to be that at least synthetically right now, the patient seems to be okay from an albumin and total protein standpoint. So I think we have that. We'll see how volume depleted the person is, and as we resuscitate them with fluid potentially, then maybe those will change. But it's unlikely for them to get to a point where it would be signal to that hypothesis being present. But I'm open to things being wrong. I think the only other thing is the kidney dysfunction, which again, we'll try to understand if it's chronic or acute. I think, again, we sort of had a component to maybe there's a volume depletion or a sort of hemodynamic component to the renal injury. And so probably I wouldn't invest too much into that until we gave fluids and saw what happened. And I think a UA being bland and not showing anything is potentially supportive of a hemodynamic uh, hypothesis for what's happening with the renal dysfunction. So how I would proceed at this point, I think, as Kirtan alluded to, there's sort of like a first pass, a second pass, a third pass. And in our first pass, we didn't find anything exciting. So we're probably going to move on to the less common blood tests that you would order than as far as like if you're in the emergency room and order like, common panel that everyone gets when they come to the hospital. Like we've exonerated most of those things. And we're going to be going on to the next things and be more thoughtful. But I think to our point here, like there seems to have been some sort of executive dysfunction. I really like Kirtan framing it that way. I think it was too narrow-minded of me to frame it as frontal lobe dysfunction. So of executive dysfunction, it seems to be resolved at this moment in time. So we can sort of invoke the possibility of this being intermittent or episodic disease, which has its own framework, and we can work through that. But I think we'd also want to think through the metabolic vulnerabilities that this patient has, because there are other ones that we'll probably want to assess. But that's where my mind is at right now, Kirtan. I'm not sure what additional thoughts you have.
Yeah, sure. Thank you, Austin. And in fact, I'm going to cheat a little bit. Like, I will ask Julia before I share my thoughts that what was going on? Like, do we have any collaterals at this point in time, or do we have any like clarification on what's this shortness of breath? What's this hypersomnolence? Is it like one-time thing or hypersomnolence was chronic? So, Julia, do you have any other additional clarification of symptoms at this point in time?
Yeah, so about the mental status, this is actually the first time that the patient had. There was nothing going on in the past regards this like orientation. The patient has this fatigue for a long time, as I mentioned, but I'm not sure about the reason why, if this is because of the heart problem. I'm not actually sure about this. I just know about the mental status and the confusion that was just starting like some hours ago. I don't know if
I
I
see.
answered
And
all of your questions.
Mhm. No, no, that's good, Julia. And then final clarification I had was that at this point in time, how many hours into the hospital we are, and did anything change, or is she or is it still the same? Like similarly, like no focal deficits, but just cannot answer your question. Is that how it is?
Yeah, when he arrived at the hospital, he was better. He was answering questions, alert and oriented times three. So it seems that was like confusion that happens for some time. And then when he arrived in the emergency department, he was a little bit of like confused about like year of the president or y- which year were we and things like that, but it was like better than he was before. So yeah.
Perfect. All right. Thank you for clarifying that. And this is the best part about discussing with someone like Austin, that like when they discuss, like they will mention like some shrewd points here and there, and that will give you the kind of spark which you needed. Like, so when the Austin was describing this, that there is this disconnect, everything looks okay, like the labs are like not screamingly abnormal, like they are mildly abnormal, and how we will tie this with apparently normal examination, right? So first point I wanted to mention was that, let's say for a moment that this person might have some degree of liver dysfunction. Then what kind of liver dysfunction are we entertaining, right? Because apparently the synthetic function seems to be doing fine. Like we don't think this person has like INR of 10, right? We don't think that this person has liver failure, right? And apparently albumin is also normal. So very important to understand that you we assume that someone can have complications from liver disease only when they go into the acute liver failure stage, but that's not true. The reason why liver dysfunction can be terrible is because of all this vascular shunting which happens secondary to cirrhosis. So in reality what you are looking for is the vascular shunting, not the cirrhosis itself, in this critical context, in this particular context I'm talking about. So if you imagine that if someone has so much congestion going on, is it possible that they have non-cirrhotic portal hypertension, kind of like post-hepatic portal hypertension, because of all this congestion in the hepatic vein? And when there is so much congestion, and once you get portal hypertension, you will shunt all the toxins from your body directly into the systemic circulation. And that's how sometimes people who have all these aberrant shunts can develop hyperammonemia, right? So in this person, although we may not have all the classic evidence, but based on how Austin explained to us, I would definitely get the ammonia level in this patient, make sure that there is not a component of hyperammonemia which can be contributing to this altered mentation kind of picture, right? So that's the first hypothesis. Second hypothesis, that for a moment, if we ask ourselves that so far all we know about this person concretely is that this person has acute onset, some kind of strategic dysfunction of the brain. We don't know about the shortness of breath clearly. We don't know about the hypersomnolence. So let's put it aside because it's certainly not looking like the center of gravity as of now, right? So in a way, we are dealing with a young person with just frontal lobe dysfunction, right? So what can do it? And apparently examination is fine. So let's start basically that what part of the brain is important for maintaining your orientation, maintaining your alertness. So we talk about the dorsal prefrontal cortex, then we talk about the bilateral hippocampus, and then we talk about the bilateral thalamus, and then we go to the brainstem, right? How can we impact these structures acutely? So one very common way is you have a vascular etiology going on, right? Maybe you have a hemorrhage or maybe you have a ischemic stroke. Now, how can you get a strategic stroke in such tiny regions of the brain? If this was an older person with hypertension, sure, you can get a hypertensive hemorrhage in the basal ganglia, and that might explain some of the findings, right? But in a younger person, if this happens, you always worry about the genetic vascular disorders or genetic vasculopathy. So, for example, people with Moya disease sometimes end up getting bilateral thalamic infarcts. And when you have bilateral thalamic infarcts, it can affect the way your cognition works, and you could seem completely altered without any focal deficit because thalamus itself, as such, is not going to affect your motor pathways, right? Similarly, sometimes people can have a variant anatomy, so which is known as the artery of Percheron infarct. So in reality, thalamus derives blood supply from two different arteries, but in some people, there is a single artery, which is artery of Percheron, which bifurcates and then divides into two arteries and which supplies both the thalamus. So in these people, since it's just one artery, if that artery is blocked, you can get bilateral acute thalamic infarcts and you could have such kind of presentation. So I am thinking that is it possible that this person has a vascular etiology which affected the deep brain structures? Second possibility, that we still don't know about this patient's like drug and toxin history. I know that this patient, from what we know, is not using substances, but are we sure that there is no substance involved? Probably not, right? So we will get the urine drug screen because many of the substances which you can use, like let's say opioids, cocaine, all of them have tendency to affect the deep g- gray matter of your brain. There are various names of the fancy syndromes. I don't want to go into the name of those syndromes, but we label it as like the toxic leukoencephalopathy, and which can affect hippocampus and thalamus and can present in this way. So urine drug screen will be absolutely essential. Then you start wondering that what other things can affect hippocampus apart from the toxin and vascular. Then the third thing is the what we discussed in the first part, that can this person have some molecule, right, like the micronutrient deficiencies. So can this person have thiamine deficiency? which is presenting with acute onset Wernicke's encephalopathy kind of picture, right? And maybe you don't have ocular dysfunction yet. So I will get the vitamin B1 levels for sure because it can cause a strategic dysfunction, right? Similarly, if you ask yourself that when you are having protein losing enteropathy, maybe you are losing some immunoglobulins as well, and maybe you are vulnerable to some infections. So you will, although the basic infectious workup is negative, but what about the strategic infectious workup? Like, would we get HIV? Would we get syphilis in this person? Absolutely, right? Because both HIV and syphilis can present with such focal neurological deficit. So we will get that. And then finally, to the Austin's point that we have done the basic workup, we don't know the answer. Then let's get the MRI brain with and without contrast to see if we are finding any pathologies in the deep structures of the brain. And based on what we find, we can tailor our differential subsequently. So that would be my first pass approach. What do you think, Austin? Anything else?
No, brilliant. Bringing in neurovascular anatomy to understand it at the depth that's really incredible. And I think at the end of the day, really what you said is, going back to the problem, like the only thing objective we have so far, at least from the limited collateral information we have, is like this person was confused and it seems to have gone at this point. How can we solve that? And it's really that principle that's most important. And then you said, hey, like this is the pathway of almost the mnemonic, but just sort of the vascular component that you added to it. So no, really brilliant. So yeah, Julia, excited to hear more.
Wonderful. I love your thoughts. So as Kirtan mentioned, his ammonia was elevated 138, together with coagulation labs. So PTT was 14, ENR of 1.3. At this point, he received 1 liters of lactate ringer and lactulose. Chest X-ray was normal. And one thing about the history that I did not mention at this time for the discussion is because this patient had a history of fountain-associated liver disease. So, with that in mind, what are your thoughts and what you will want?
I think Kirtan, it's your turn. But I'm happy to go whenever you like.
Oh yeah, sure. Yeah, I actually missed it. So yeah, it's my turn. Perfect. So well, friend, like as Austin predicted, right? That hey, there is so much congestion. Maybe they have some degree of liver dysfunction, and then as we discussed in previous aliquot, that you don't need to have actual cirrhosis to cause dysfunction because it's more about the vascular shunting, right? So looks like that in this case, we thought that maybe this person can have non-cirrhotic portal hypertension. We obtained the ammonia and it is high. Now again, a caveat which I wanted to mention that oftentimes medicine can be complex that you find one entity, but are you going to put all your money in it, right? That is it the sole explanation or not? In this case, it could be the sole explanation because as we were discussing earlier that there is no focal deficit, maybe it's a chemical or molecule, that's why we entertain getting ammonia. But still I would like trend the ammonia levels, and if the patient's cognition doesn't improve as the ammonia level goes down, then I will pursue the imaging and other workup so as to not to get biased. But as of now, the ammonia is high. Then the point is how to fix the ammonia levels. Now, often when people have cirrhosis, fixing ammonia is like we give them rifaximin, we give them lactulose, kind of clear the gut synthesis, right? But when people have such shunting going on, often the way to manage it can be tricky, and you might need to involve the hepatology colleagues and the nephrology colleagues to use certain unique molecules like which can chelate the ammonia and then you can pee it out. Like often we use such agents in people who have urea cycle disorders. So kind of like that, you have to think that how will you manage this person. So that's what I'm thinking, that maybe ammonia is coming from this vascular dysfunction at the level of liver. And maybe I can ask Austin that what are his thoughts.
Yeah, I think you're doing such an important principle of like, hey, we've found something, but is it adequate enough to explain the clinical syndrome? Because all the time in medicine, again, usually going back to a 60-year-old person, we get a CT scan because someone's having abdominal pain, and we find that they have a renal cyst and they have a lesion that looks like RCC and they have diverticula and they have, you find so many things, but are they actually explaining what's happened to the patient in the moment? And that's a really important exercise for any testing you order. So Julia gave us a nice exercise of not telling us that the patient had known liver disease from their Fontan procedure. And so, or as a consequence of their Fontan procedure. So, what do I make of that? I think one way is to say if you didn't know that and you saw the hyperammonemia, I think it's really just easy to say, hey, this is an acute liver dysfunction, or there's a shunt that's happening. Um, and that is why the person has hyperammonemia. Let's address the hyperammonemia and see if it gets better. In this context, since we know that the patient has liver disease, maybe an ammonia has been checked in the past, and we can use the delta, as Kirtan was mentioning, to see um, if there's any improvement. But I think at this point, you'd say, hey, like there's so much that we don't know that I'm going to address the ammonia as best as I can and see what happens to the patient. But for me, and someone that has known chronic liver disease, this ammonia for this presentation is not enough for me to feel good about the results. So I would be going for treating the hyperammonemia and trying to address it, but simultaneously continuing the workup. I wouldn't feel satisfied with just being like, hey, let's treat the ammonia and then not do an MRI or not do an LP or not order more metabolic testing at this point in time. And that's my personal opinion. And that's just because I think we love to check ammonia, and particularly the chronic liver disease space. It definitely has a tremendous role when there's an acute uh, presentation and you know that the person doesn't have pre-existing liver disease or a clear vulnerability to it. But in this context, I think ammonia gets blamed a lot. And then we don't have a clarification. I think additionally, at least in my experience with patients that have liver disease like hyperammonemia resulting from chronic liver disease, this whole presentation does not fit with my like typical illness script for it. It certainly can, because it's relatively common, I'm sure it can manifest in different ways, but it just doesn't my gestalt and my gut sense is like I'm not satisfied with it, so I wouldn't go with it. But Kirtan, any other thoughts before we pass it back to Julia? I'll take the silence as a yes or no. So, Julia, go ahead to tell us what happened next.
Yes, sure. So the patient got a head CT that didn't show anything, no acute intracranial abnormality. The US abdomen was done that showed liver with mild nodular surface, no portal vein thrombosis, no ascites. He also had a CT abdomen that did reveal dysfunction-associated liver disease, no suspicious lesions, small hypervascular, probable like focal like lesions. Also some splenomegaly and a large splenorenal shunt. So the final diagnosis was hepatic encephalopathy due to large spontaneous portosystemic shunt in the setting of Fontan-associated liver disease. This patient was started on rifaximin, lactulose, and supportive care with rapid improvement in mentation and resolution of confusion. Diuretics and losartan were held on admission due to acute kidney injury that he had and hypotension that was seen during the admission. Then resumed. During hospital stay, he developed transient hypoxia and mild pulmonary edema, requiring some supplemental oxygen, which resolved with diuretic. CTHS was negative for pulmonary embolism at this moment, but showed mild pulmonary edema and traced right pleural effusion. Other issues addressed during this admission included the iron deficiency anemia, for which he received a missed outpatient iron infusion prior to discharge. His chronic cardiac history was reviewed with device interrogation, and outpatient follow-up with hepatology was arranged for ongoing management of this hepatic encephalopathy and Fontan-associated liver disease. So this was the first time that the patient did had like the hepatic encephalopathy during all of these years of Fontan-associated liver disease. And yeah, I want to know what are your thoughts about this diagnosis?
Yeah, no, incredible. And thanks for the teaching on that. And yeah, unfortunately, the patient had some complications during their hospital stay, which I imagine just like speaks to the very tenuous fluid balance that this patient has to keep because of their cardiac disease history. So, I think what I take away is, going back to the beginning of like, the patient sleeping for 20 hours and feeling fatigued and tired, like all of that is definitely consistent potentially with having symptomatic hepatic encephalopathy. The first sign of hepatic encephalopathy, actually in the clinic setting, so not in the hospital setting, is actually the sleep-wake reversal. So your sort of sleep cycle is reversed from what we consider to be normal. So sleeping more during the day and more awake at night. So that is potentially consistent with hepatic encephalopathy that was brewing and then developed. I think I'm asking myself, it takes a while, typically speaking, to develop a splenorenal shunt. So why now? And I think it's possible, everything has to debut at some point in time. So maybe it's just there. I wonder if there's some other vulnerability that the patient experienced, like a viral illness, a vitamin supplement medication, a change in how they were taking their medications, et cetera, that then sort of tipped them over the edge. But that's just sort of kind of rationalizing to myself, like why now? Like why would this suddenly occur in this particular scenario? And I don't really know of the answer, but that's a curious space to find myself in. Um, yeah, a really interesting case, fascinating. I've seen splenorenal shunt one time before in the setting of this type of like congenital cardiac history, and I'd 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 I helped to diagnose it, but only after like much disarray as far as like getting to the answer, and it sort of manifested in a different way. But really, really interesting. Yeah, Kirtan, what are your reflections?
Yeah, no, of course. Thank you so much, Julia, for presenting this case. And I will just tell everyone that, like, if you just go to our website and see the schema of hyperammonemia, one of the first thing which is mentioned there is that there is photosystemic shunt, right? Now, cirrhosis is just the apparent most common cause of that, but there are so many other causes, right? So I remember Mark has presented a case in the past of someone with splenorenal shunt, which happened after like some endovascular procedure or some splenic pathology, and then patient ended up presenting with like hyperammonemic encephalopathy like months and months later. So to the Austin's points, it's similar to like that, right? That although this person has a chronic issue, but at some point in time, something happens. Maybe they just become metabolically vulnerable from any other standpoint, and then they just manifest. But it's good that you found the answer, so now you can fix it. And just like this shunt, like splenorenal shunt, all the possible shunts in the intestine can do this. So, like, I have heard about people with like hereditary hemorrhagic telangiectasias having like systemic AVMs in the liver, systemic AVMs in the intestine, and which can also present in similar manner. Because after all, what you are doing, that all the toxins which are going through your portal vein to the liver, you just want to divert them. How you divert them, that let the body decide, right? But basically, that's how it happens. And how will you figure it out? You just get a CT angiogram of the abdomen, and maybe you will find it. And if not, you can also do CT angiogram of the chest. Maybe sometimes the shunts are in the above part of the body, which can also cause such pathology. So I'm glad that you guys found it, and hopefully the surgeons can fix this shunt, and this person will be free of all the pathologies in the future. Yeah, thank you so much.
Yeah, Julia, any final teaching points or takeaways before we pass it to Sam to teach us?
No, just thank you for the amazing discussion. I was preparing something to teach about the fountain, but Kirtan and Austin did an amazing job teaching us about the procedure, all of the complications. So that's all. Thank you, everybody, for being here. And I think we can pass the mic to Sam.
Thank you so much, Julia, for bringing this case. This is incredible learning for everyone. And there was just so much incredible stuff happening in the discussion. It was all I could do to keep up with Kirtan and Austin. So thank you both for sharing your wisdom with us. Um, we started by learning the importance of clarifying the problem of confusion, which is a very common thing that we are told is the problem, and that can mean any number of different things. So getting as good a handle on the time course, the exact symptoms as you can, and of course, the importance of getting collateral information from people who are not confused to help you with this. Um, Reviewed our favorite missed mnemonic, but we also got to hear a little more about the scan and the don't mnemonics as further ways to think about altered mental status, which is wonderful. We've talked about our basic workup and how important vital signs are in an altered and confused patient, and not to overlook those very basic steps in search of a more rare diagnosis. Um, We reviewed a lot of neurolocalization, so thinking about executive dysfunction and where along our pathways those can happen. Um, we also got to review a lot about the postictal state, symptoms of seizures, and what things should be higher up on our list for young patients. So things like autoimmune disorders and space-occupying lesions, and endocrine problems. So those should be high on your differential as opposed to more degenerative processes. And we learned so much about the Fontan procedure. So I'm again so grateful that we got to hear this case from Julia. Um, we got to talk a lot about shunt physiology and how that will affect essentially the whole body, so causing AVMs in the intestines and the liver, um, and how those that shunt physiology itself can lead to hyperammonemia, which may cause altered mental status, or there are other problems further down the line, such as malabsorption causing micronutrient deficiency or protein losing enteropathy. Um, yes, and we also, I think, yeah, we talked about how your exam will affect your prioritization of the differential for infectious causes of altered mental status. Um, I think. And then, oh, okay. I think another great thing that we took away from this case would be once you've identified liver dysfunction, determining whether that is the sole cause of your clinical problem, or if that is part of a larger picture and the importance of doing the rest of your altered mental status workup as far as can you blame all of this on hyperammonemia or can you not? And so I think we got some really great teaching about that as well. Thank you, everybody.
Yes, excellent teaching and summary, and there was a lot of things said. And yes, Kirtan is also a neurointerventional radiologist and a pediatric cardiovascular surgeon, and all the things. He's just that brilliant and amazing. So yes, thank you to Sam, to Sini, to Julia, to Kirtan. Really great to see everyone. Happy holidays to those that celebrate, and we'll see you next time. Bye bye.